Good evening, everyone, and welcome to today's wonderful evening with Dr. Murli Bharadwaj. Very happy to see our old comrades joining back on the news that we started pediatrics today. If that is the case, I don't mind restarting right from anatomy, right? So if you guys can come every day. So thanks to Kaushik, Bharat, Mithuna, Jaiswal, and many more who are all online. Ashok Naik, Harika, Shweta, Afroz, and Karthik. Thanks for joining the session. Inform your friends. So, doctor, pediatrics, it's very easy. 10 marks आएगा pediatrics में. Pediatrics बोले तो इतना मोटा बुक है नेल्सन, जरा पतला है गाय. गाय का बेटा को क्या बोलते हैं? गाय के बेटे को हिंदी में बछड़ा. गाय का बेटा बछड़ा, बछड़े का बछड़ा, बछड़ा. Shortest review of the notes of the entire guy is 32 pages notes. How much time will take to revise this? Maximum 12 to 14 hours, right? So till Tuesday we will do the revision of pediatrics. Then once more we will start our daily grand test and discussion. So doctor, Apgar score, what is it? Apgar is the quantitative method to assess the respiratory, circulatory, neurological status. So what are the 5 criteria under Apgar? A for appearance, that is the color of the baby. P for the pulse rate. Actually, it is heart rate. G is the grimace. If you touch with the catheter on the nose, is the baby grimacing or not? A is the activity, that is the muscle tone. And R is the respiratory effort. Is the baby crying or not? Constitute the Apgar score. So you need to be doubly sure on calculation of the Apgar points and accordingly what is meant by severe, moderate, and excellent. Clearly, just like you remember Glasgow Coma scale. In every NEETPG, they will force you to calculate the one of the scores. Child Puke's score in cirrhosis of liver, Glasgow Coma scale, Ranson's criteria, Apache score. So one score wala question jarur aayega. Abhi, if you go back to the score app, in that if you click on the search button, score bol ke maro, kitne notes aayega, kitna MCQs aayega. So we added a lot of almost 30,000 new question bank in the search, so that now lithium bole to almost 200 questions based on lithium will come in different contexts. So doctor, Apgar scoring system activity, the muscle tone, if it is absent, atonic, score bole to kitne aaye Kaushik? Score मारे तो
248 questions and 29 notes.
129 notes.
Was it 29 notes?
29 notes.
And 248 questions.
248 MCQs if you hit the score as the search button. But tuck revise karna last moment mein. Then arm and leg is flexed is 1 point, the active movement is 2 points. Pulse below 100 is 1 point, above 100 is 2 points. Grimace, flaccid or some flexion or sneezing, coughing, pull away. Skin color is blue or pale or body is pink and extremity is blue. This is a very common description given by the examiner. Typically, he will say extremities are blue or body is pink or completely pink is 2 points. So this is Apgar scoring. It is called severely depressed if it is 0 to 3, moderate it is 4 to 6 and excellent is 7 to 10 is what you need to remember. So once more, Apgar score, how to calculate, is one of the favorite areas of the examiner. So you calculate within 1 minute, you learn in 5 minutes, and based on the total scores, mild, moderate, and no depression, you have to be 100% sure about. Now, what is important about Apgar score? You are assessing the newborn baby, but is the respiratory rate included? No, sir. No, sir. Common MCQ in exam. All these are the part of the Apgar score, the body tone, the body color, activity. Is the respiratory rate involved? Then first time if you guess in the exam hall, you will give an Einstein-like answer for a simple question, right? So Einsteins don't get seat in NEETPG, right? So respiratory rate, just like amylase is not included in Ranson's criteria. Ranson is for pancreatitis, but amylase is not included. Understand? So respiratory rate is not included. At 1 minute, normal baby will get a score of 7 to 10. In asphyxia, 4 to 6 is mild depression, 1 to 3 is severe depression. Any depressed neonate with score less than 7 usually improves if you put oxygen therapy to him. You can do that with a hood, face mask, with or without positive pressure ventilation. Then, if the Apgar score is less than 3, then that is an indication for external cardiac massage and tracheal intubation. So tomorrow, when one of your colleagues has delivered a baby, being an obstetrician, as a pediatrician, one of the challenges is a low Apgar baby, how to handle him immediately. Emergency neonatal resuscitation. Any apnea which occur at the birth is considered to be secondary apnea. And secondary apnea, there is a fall in BP and heart rate also begins to fall. But generally, with low Apgar score, only 10% of babies will go to that situation where you need to do external cardiac massage and all the resuscitation. So if the baby is full term, if he's crying, if he has a good muscle tone, then what will you do to that baby? Common MCQ. Put the baby to the mother's abdomen, kangaroo care, so that it will be all right. And after how much time you need to cut the cord? You need to give 2 minutes. 2 minutes, so that some amount of blood transfusion occur, and that will avoid a lot of anemias. So this is how resuscitation, intubation is done whenever the patient is, whenever the newborn baby's Apgar score is less than 3, is a golden number which you need to remember. Now, going ahead with torch group of infections. I'll keep shifting from one topic to other. Once more, I may come back to the Apgar, mainly to avoid monotony. IUGR, thrombocytopenia, where do you see? CMV, rubella are the two infections where IUGR and purpura with thrombocytopenia is seen. So common question, among the torch group of infection, in which group IUGR is not a feature, syphilis mein nahi hota. Then how do you detect toxoplasmosis? What is that acronymous name test called as? Sabin-Feldman's dye test, which will detect the IgG in case of toxoplasmosis. If you look at the PDA, if the PDA is there in a term baby, see, a preterm may having PDA is different. Term baby may PDA is different. So what is the common torch group of infection that lead to patent ductus arteriosus? Rubella. And whenever PDA is there, it requires surgical correction in a term baby. Whereas in the case of the preterm baby, if there is any open PDA, then how will you close it? Prostaglandins keep the PDA patent, is what you need to remember. Prostaglandin keeps the PDA patent. So giving indomethacin ibugesic will close the PDA, is what you need to remember. So how do you assess the preterm baby, doctor? This is one of the favorite questions. How is a preterm identified? So fundamentally, all these excessive creases is one of the very important feature that you see in the case of the preterm baby. Now coming to HBV. How is HBV transmitted? Hepatitis B. Through the birth canal, rarely in utero. 60 to 90% of the affected newborn become chronic carrier of the HBV, which increases the risk of their developing cirrhosis and cancer later part of the life. Hepatitis in early infancy has a greater chance of developing the future cirrhosis. That's the reason maternal HBV is very, very important. Now, if you look at the mother's virological profile, those mothers which are HBsAg positive, they are highly likely to transmit the hepatitis to children. Suppose if already anti-HBs antibody developed in the mother, her transmitting to the baby is less chance. But if she is surface antigen positive, then there is a greater chance. And all neonates who are born to the HBs positive mothers, what do you do, doctor? You need to give the hepatitis B immunoglobulin. How much? 0.5 ml IM plus active immunization with the vaccine. 10 microgram dose in 0.5 ml suspension, preferably within 12 hours of delivery, is what you need to remember. And later, 3 more doses of the Hib vaccine. Generally, in immunization, we give Hib, hepatitis B. So that anyway you will give. Now, what is the chance of developing hepatitis B after maternal exposure to HBV? In first trimester, if the mother is HBsAg positive, risk of transmission is 10%. In third trimester, if she is HBs positive, HBe negative, the risk of transmission is 5 to 10%. At the similarly, towards the third trimester, if she is HBs positive, HB envelope antigen negative, transmission risk is 5 to 10%. At the time of delivery, if HBsAg positive, HBe also is positive, the risk of transmission is almost 90%. Because envelope antigen is indicator of viral proliferation, is what you need to remember. Now comes 5 cleans of intracranial care, intranatal care, sorry. So, very good to see 20 online students. Today, Diksha, just like you, Harika brought 2 of her classmates. So today there is a test for you, sir, how well you will teach. Jara prepare hoke aa jao, sir. Nahi to, I gave a lot of expectations to my classmates. I thought, एक टेस्ट तो पास हो गया, दीक्षा पास किया, MRCP तो खत्म हो गया, अभी FRCS का एग्जाम है, क्या बोलते हैं, इम्तिहान. Exam is called Imtihan. So I like to listen from Harika's friends how they felt compared to many Georgia University teachers. How did Begumpet teacher is able to teach? Huh? Sir, Begumpet teacher is more gorgeous than the Georgia teacher, sir. So, very good, very good. Can online students can punch, doctor? Well, the voice is loud and clear for all of you. Now, 5 cleans: clean hands, clean delivery surface, clean blade, clean tie for the cord, and clean cord. Right? Now, what are the NRP guidelines? That is neonatal resuscitation guidelines have changed in 2015. Earlier neonatal resuscitation guidelines, modifications in 2015. Favorite question. Number 1, cardiac monitoring is done by ECG. Algorithm starts with antenatal questions. Whenever you are resuscitating the neonate, what is the cause for his neonatal distress? There is a bearing of antenatal findings. So that's the reason those history need to be taken. Then, so typically 30 seconds, 30 seconds, 30 seconds. That's how you divide. If it is a term gestation, amniotic fluid clear, breathing or crying is there, good muscle tone is there, what will you do? Sorry. Good muscle tone is there, what will you do? You provide routine care. अच्छा भैया, routine care क्या होता है? Provide warmth, clear the airway, assess the color. Keep him dry. Okay? Then, if it is not so, if it is not term gestation, amniotic fluid is not clear, breathing or crying not there, and good muscle tone is not there, how do you want to manage? Provide warmth, clear the airway as necessary, dry, stimulate, reposition. Then you evaluate respiration, heart rate, and color. If the breathing and heart rate, breathing is there, heart rate is more than 100 and pink, then put him on observational care. Suppose if he is apneic or if the heart rate is less than 100, then you need to provide positive pressure ventilation. Suppose if the breathing is there, heart rate is more than 100, but if he is cyanotic, then you give supplementary oxygen. And if he turns pink, then just keep him observation. Suppose if he is persistently cyanotic in spite of giving oxygen therapy, even though the breathing and heart rate are normal, then positive pressure ventilation. If effective ventilation given and the heart rate improved and he became pink, then you do post-resuscitation care. Suppose you provided positive pressure ventilation and the heart rate is less than 60, then you provide positive pressure ventilation and do the chest compression. And if the heart rate is still less than 60, then you need to give epinephrine and or fluid volume. Suppose if the heart rate is more than 60, then you need to once more continue the positive pressure ventilation and move him to post-resuscitation care. So this is the algorithm of NBR, which you need to remember. So examiner क्या करेगा ना कल के नीट पीजी में, इसमें कहीं ना कहीं तक ले जाके नेक्स्ट क्या करोगे बोल के आपको पूछेगा. तो इसलिए ये जो रिसर्सिटेशन प्रोटोकॉल है वो इधर खोपड़ी में बैठ जाना, दिमाग के अंदर बैठ जाना. ठीक है? हाँ. So what are the new guidelines which you need to remember? Examiner will expect you to answer like कौन बनेगा करोड़पति contestant. Affirmative answer, yes, no, you need to give. No guessing in exam hall. Routine intrapartum oropharyngeal, nasopharyngeal suctioning of the babies born through meconium stained liquor. Do we do it now? Earlier days, meconium stained liquor है तो वो पैदा होते कि बुस 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 we used to aspirate. It is no longer advisable. For term babies, first 5 to 10 breaths should contain 21% or room air. If the baby is cyanotic, or if positive pressure ventilation is required during neonatal resuscitation, then you need to give 100% oxygen. So when do you want to give 100% oxygen? 21% is enough, room air is enough for the newborn baby. But if the baby is cyanotic, when the positive pressure ventilation is required during neonatal resuscitation. So whenever the supplementary oxygen is not readily available, then with room air only start the positive pressure ventilation. Then that is the story of the term babies. For preterm babies, how do you do? What do you do? Begin PPV with oxygen concentration between room air and 30 to 90% oxygen. You can say 40% FiO2. Clear? Preterm or term, the newborn care in the labor room or delivery room, you need to be very clear. Increase the oxygen concentration up or down so that you achieve the target saturation, blood saturation. If the heart rate does not respond by increasing rapidly to more than 100 per minute, you look for any ventilation problem and use 100% oxygen. But otherwise, 30 to 90% oxygen to room air is enough for term baby. And you should check that the heart rate is more than 100. If it doesn't increase to 100, then give 100% oxygenation. Now, when it comes to PPV, positive pressure ventilation, laryngeal mask airway should not be used in which situations? What are the contraindications to using the LMA to provide PPV? You need to be very sure on this contraindications. One of the favorite questions. Whenever there is a meconium stained amniotic fluid, if meconium stained amniotic fluid is there, it is a contraindication for laryngeal mask airway. When chest compression you need to do, don't do LMA. In very low birth weight babies, don't do LMA. For delivery of medications, don't use. Naloxone need not be given by endotracheal route. And what is the way during the last step of resuscitation? Epinephrine, only intravenous route only. There is no other subcutaneous or any other route. And how do you know whether the ET tube is in place or not? This is one of the favorite questions. Capnography. End tidal carbon dioxide levels, when they drastically increase, then that is an important indication that there's a tube misplacement. Now, one very important thing you need to know is the shoulder roll, headrest. So if you do hyperextension of the head on the neck, that lead to airway obstruction while resuscitating, hyperextension. So be sure to position the head and neck in a neutral sniffing position, right? Not sneezing, sniffing. Sniffing is the tobacco sniffing is, anatomical snuff box, which may require a roll under the shoulder, headrest, tongue lift, jaw thrust. So this is a very important part. So this is one of the favorite MCQ doctor. Supriya Roy says, sir, kindly zoom it. Yeah, I love to, but unfortunately, anyway, once more we have all these PowerPoints are there, Supriya, in the score app, so you can always do the revision. Otherwise, these are available in every book. Mainly point is, My job is to take your finger and say, e, to show you where to read in the book and what to focus in the otherwise guy. Guy and Bachada always memory will be much higher because that's what we studied throughout our MBBS, right? Or we did not study. We studied, right? So generally 30 days before final year exam we buy guy. 1 week before exam we will open. Then first 3-4 days strategy, what to read, what to not read. Some senior will put IMP, this. Finally, one day we read, get distinction scores. Already you are tuned to prepare 60 days May NEETPG top rank. Already your genes are created for that. So don't tell me that, sir, how to manage last 50 days. MBBS only we managed last 1 week, last 4 days, last 5 days, right? So very good. So yes. Apnea or gasping and heart rate below 100 per minute. If it is not there, look for labored breathing or persistent cyanosis. If it is there, then position and clear airway, SpO2 monitoring, supplementary oxygen, consider CPAP. If apnea or gasping is there or heart rate is below 100, then PPV, SpO2, consider ECG monitoring. Now, what is the targeted preductal SpO2 after birth? Saturation of oxygen. 1 minute 60 to 65, second minute 65 to 70, third minute 70 to 75, by 10th minute 85 to 95% को आ जाना फायदा होते ही हमारा ऑक्सीजन, जस्ट लाइक नीट पीजी मॉक टेस्ट स्कोर्स. अब कौन सा लेवल में है बेटा? थर्ड मिनट अबगार लेवल में है या मॉक टेस्ट लिए तो मॉक टेस्ट में मोस्ट ऑफ यू आर हिटिंग अराउंड 100. सी द प्रेजेंट मॉक टेस्ट दैट यू टेक नो, डेली हम एक फुल स्केल नीट पीजी मॉक टेस्ट कंडक्ट करते हैं. वो आपको डिप्रेस होने के लिए नहीं है, वो खाली किसके लिए बोले तो मिनिमम 200 क्वेश्चंस को ले लो, उसका जवाब देखने के बाद याद रहता या नहीं याद रहता, that much is enough. Just to be in the game. 30 days you play the game, you finished 6,000 MCQs revision. Already 20 papers we finished. Another 30 papers you finish, 6,000 you finished. Last 20 papers ना, उसमें आपका स्कोर अच्छा नहीं है तो टेंशन ले लो, मैं मान लेता हूं. मगर पहले दिन से टेंशन के लिए तो मॉक टेस्ट इज नॉट, सही बात नहीं है. तो फर्स्ट 20 मॉक टेस्ट आर टू चेक वेदर आई कैन सिट फॉर 3 hours, take whether I am right or wrong 200 questions, listen this old man talking discussion on 200 questions, बाद में जाके उसको आंसर्स को रिप्रोड्यूस कर सकते हैं या नहीं. Are you able to do that for the first 20 days? Then you are ready. Pre-ovulatory phase. Next 30 is secretory phase. Last 20 is by the time progesterone level should be good and there should be no bleeding. Right? So that is the plan. Now, doctor, mask ventilation. What is the main pitfall of mask ventilation? When you are giving mask ventilation, if you do overbagging, that lead to pneumothorax, pneumomediastinum. So that is the reason, avoid overbagging. How do you avoid that? You try to only cause adequate chest rise when you are doing the AMBO. And PIP, positive inspiratory pressure, should be kept at 20. If you are using a CMV means continuous mode ventilation. Then how do you deliver the PPV? Positive pressure ventilation. We use a T-piece resuscitator or a flow inflating bag. You remember Mapleson systems? Ayers, T-piece, Jackson Reef modification, all that lousy ABCDEF. మధ్యలో ఏదో ఒకటి ఉండదు కదా, అన్ని ఉంటాయా? ABCDEF, राइट है? तो वो बोरिंग एरिया का टी पीस को ला लो. अय्यर टी पीस है ना, अय्यंगार नहीं, अय्यर. So how much CPAP you need to maintain? 5 to 8, and PIP should be 20 or until chest rises when the PPV is delivered. So why do we give a positive airway pressure, doctor? Fundamentally, what is the underlying cause? See, this is alveolus. This is the airway. So when the air is exhaled and it is leaving out, right, there are some collapsing pressures which try to collapse the bronchus. What is the thing that prevents that collapse from happening? Who provides that intraluminal opposing pressure to prevent the collapse? It is the surfactant that provides the elasticity to this alveoli. So in the preterm babies, etc., where your surfactant is not adequate, then they don't provide enough amount of intraluminal pressure. So that is the reason when the air is half the way, only the lumen collapses, right? Lumen collapses. To avoid that, you need to maintain positive end expiratory pressure to keep the lumen open for the expiration to happen. So that is the fundamental basis. Why emphysema is a obstructive pulmonary disease? Emphysema means problem in the alveolar structure now. In emphysema, when the alveolar structure is destroyed, then the intraluminal pressure will not be available to keep the airways patent while you are expiring. So same problem even in emphysematous individuals. Here, because of the lack of surfactant. So that is the purpose of continuous positive airway pressure and positive end expiratory pressure to keep the alveoli and to recruit the lungs is what you need to remember. So whenever heart rate is below 100 per minute, then you need to check for the chest movement, ventilation, corrective steps, endotracheal tube or laryngeal mask if at all it is required. Then remember MR SOPA. MR SOPA. After 30 seconds of ventilation, if no effective improvement of clinical status is there, then you need to remember the protocol MR SOPA for corrective ventilation. So what is MR SOPA? M is adjust the mask. R is reposition the airway. Maybe you passed the endotracheal tube so deep that it went into the right bronchus seeda. Could be possibility. Do suctioning of the nares. Open the mouth. Pressure increase to PEEP 6 to 8 and PPV more than 20, maximum 40. Otherwise, there will be alveolar injury. And advanced airway, consider supraglottic airway. So this is called MR SOPA, which you need to remember after 30 seconds of ventilation, if there is no improvement in the clinical status, is what you need to remember. If the heart rate is below 60, in a newborn, intubate if not already done, chest compressions, same table I gave long, no? Because Supriya Ray asked us, so Supriya, are you from Calcutta and related to Arpan Roy? Please let me know. So today one of my very old student called Arpan Roy is a pathologist in Burdwan in West Bengal. Sir, 7 साल के पहले मैंने खाली आपका नोट्स और वीडियोस पढ़ के एमडी किया. अभी मेरा बेटर हाफ है, सो वो भी preparing for entrance. I said, please welcome, most welcome. So 1+1 offer. So, so good. So doctor, after 30 seconds of PPV, you reassess the heart rate. If the heart rate is more than 100, continue PPV, 40 to 60 breaths per minute. Then if heart rate is less than 60, establish adequate ventilation and do chest compression. So these numericals are important for tomorrow's examiner, doctor. What should be the value of the positive inspiratory pressure? Less than 20, maximum 40. Heart rate, what is the value below which you will start resuscitating? Below 60 per minute. So these values try to remember. So you have 40 seconds to secure the airway of a sick neonate. You need to be very fast in intubating, just like tick mark ke jaise ho jana. And SGA is your tool of choice. Supraglottic airway is the tool of the choice in sick neonates more than 34 weeks. So always the rule is 40 seconds में 3.5 hours टाइम दे रहा है एग्जामिनर आपको 200 क्वेश्चंस आंसर करने के लिए. 200 का जरूरत नहीं पड़ना चाहिए अगर आप सही तरफ पढ़े तो. मुरली भरद्वाज के साथ फर्स्ट 100 मिनट्स खत्म. लाइक एयरफोर्स फाइटर पायलट्स, you need to go surgical, what is that called? Surgical attack. Finish. Even the Pakistan army don't understand also where the bombs are falling from, or Chinese army doesn't understand. Pakistan तो हमारा भाई है, तो Chinese army don't know where the bombs are, missiles are landing, and then you need to come out. That speed you need to fight and come. I'll be waiting outside the exam hall. Mithuna, आपका exam center बोलो. I'll be waiting like when your kid first time goes to nursery, no? That is the day you will never forget, right? You'll be waiting outside. Mera munna kya karega? Maybe he'll be crying for me and all that, right? So I'll be waiting and thinking, oh my God, maybe ECG question all our students may be answering. That's how I'll wait outside the exam hall, right? So that's the story, doctor. Now, this is the laryngeal mask airway ProSeal. This is one of the image-based MCQ in the tomorrow's NEETPG. This is the classic LMA. This is called iGel. These are the ones which are used for surfactant administration. But what is the pitfall of the SGA? If you insert SGA too far, then that becomes a damaging situation to the gut. So there are few things, too much specs about it. So let's go to the amount of the resuscitation mania. So now you got some points, right? So once more, when we solve questions on pediatrics, that time once more these keep coming. In the subject test, pediatrics में कितना टेस्ट है बेटा, एक बार देखो. सब्जेक्ट टेस्ट में कितने टेस्ट दिया होगा? 3 or 4. I think 1000 questions I gave in the subject test in the score app. So after going home, फटाफट आंसर करो. ओ सब्जेक्ट टेस्ट को खत्म कर दो.
2729
कितने?
2729 14 tests.
14 tests, 2729 questions I gave. That is obsession. But anyway, अब फटाफट you take this as an inspiration. Morning में 400-500 questions को खत्म करके उसका आंसर देख लो. आंसर्स को याद रखो. So to simplify rapid sequence intubation, you need to secure the airway very fast. What are the two drugs that we give? One induction agent, etomidate, and paralytic agent, succinylcholine. So what is the rule of twos for the neonatal rapid sequence intubation medications? Rule of two. Atropine is 0.02 milligram per kg. Fentanyl is 2 microgram per kg intravenous. Succinylcholine is 2 mg per kg. Intravenous is what you need to remember. So now, doctor, coming back to the game of chickenpox. Varicella zoster virus infection during early pregnancy. That is the first 20 weeks. What does it lead to? It leads to spontaneous abortions and fetal varicella syndrome. So what is fetal varicella syndrome contain? Cicatricial skin rash, low birth weight, limb hypoplasias, and satellite cells of the dorsal root ganglia. They get affected whenever chickenpox affects. So chickenpox stays dormantly inside our dorsal root ganglia. That's the reason varicella zoster is a reactivation of that. So when will chickenpox maximum transmission from the mother to the child will occur? Last month of pregnancy. And that lead to development of neonatal varicella. So this is the neonatal varicella where the child get scarring lesions of the skin is one of the very important feature of the chickenpox, neonatal chickenpox. Now coming to hypothermia in neonates. So what is the normal temperature of neonate? 36.5 to 37.5. Diksha, are we still interesting or is it sleepy? Pakka? Bharat? We are used to Diwali crackers like MCQ discussion. Fat ho jata. Abhi I always hate doing theory revision in the last moment before exam. Is it fine?
Very sweet, sir.
We'll have some coffee. Manu, coffee below beटे हमारा Dr. Bharat MS Orthopedics is sleeping in the middle of knee transplantation. So it was hot summer in Warangal while we were preparing myself, Gangadhar. Gangadhar is a nephrologist. Suresh is also a nephrologist. We were all sitting. We made big plan for doing revision. So plan तो बड़ा है. अच्छा मुकेश का गाना, लता मंगेशकर का गाना लगाया. बुर्र बुर्र स्लीप आ गया. So सो जाने के बाद एक घंटे के बाद one of the guy got up and said, "Hey, what a man, what about to be sleeping?" Then we went to Kaktiya University ground, hot sand, without slippers. We ran, made a thin rounds in the afternoon, 1 o'clock in hot summer in Warangal. Imagine. So we came back and nice coffee hai. Diksha, you take coffee? Then after coming back, we stopped Lata Mangeshkar. She's too motherly to make us sleep. Ghantasala Bhagavad Gita lagaya. I still remember फिजियोलॉजी गेनोंग पढ़ रहे थे. उस दिनों में 20 साल के पहले रिव्यू बुक्स कोई भी नहीं पढ़ता. हम तो गेनोंग गाइटन वही पढ़ते थे. तो गेनोंग पढ़ना शुरू किया. So whenever me, Gangadhar, Suresh, we all meet now, we remember the day of hot sand. Why bloody? And much tougher suggestion given by Suresh was, let us tie some weight to the legs and then run, then we'll get enough of this thing. So it's a question of determination. For entrance preparation is nothing to do with intelligence. Determination. Can I come? Can I read? Can I get up? Can I be in that you need to come into that maniac tinge of preparation. कभी कभी फिजियोलॉजी पढ़े तो पैथोलॉजी याद आता है, हम भूल गया बोल के पैथोलॉजी पढ़ रहे तो सडनली सर्जरी याद आता है पढ़ेंगे बोल के. Yeah, you need to hustle here and there, here and there, here and there until the end of the day. As you keep hustling, one point, threshold point will come, doctor. Which way your girlfriend will come and give you wedding card? Sorry dear, I waited for you enough. My dad found already a guy who is MS, MCH, cardio, thoracic surgery. Then you have to tell her a story. Don't marry that fellow, that fellow will only stay in the theater. He will not do anything. So I am the one unemployed, NEETPG preparing guy, and I will deliver 3 to 4 doses of love for you. Morning to evening, I load you with. Please don't. Give me 2 months time. After that, I am back to your feet. You need to beg your girlfriend. So that's all part of everyone's life, let me tell you. So nothing to bother about. Now, how do you define hypothermia in neonates? Less than 36.5. Mild hypothermia is 36 to 36.4. Moderate is 32 to 35.9. And severe is less than 32. Now, how does a neonate loses the heat? Basically, in the form of infrared electromagnetic waves. And there are 4 main mechanisms. One is radiation, conduction, convection, and heat loss by conduction is prevented by use of more than 26.6 degrees Celsius of temperature with warming blankets, drapes, and head covers. Convection, the air which is flowing in the surrounding, it is the main mode of heat exchange in the infant who is placed in the incubator. How does he get the heat? By convection. Simple things पूछेगा examiner. ये radiation है क्या? अच्छा incubator बोले तो radiating ना, तो radiator लगाए तो गया. Convection. And keep the room temperature always. The delivery room should be maintained 26.6 even if you are in Leh Ladakh. And evaporation of the amniotic fluid and moisture from the baby's skin to atmosphere. So they are all the things that contribute to the development of hypothermia is what you need to remember. So that is the reason the baby requires a good wrapping with because especially preterm babies, they're at a great risk of developing hypothermia. So that is the reason to avoid the hypothermia. The only way to avoid hypothermia is by wrapping in a warm blanket is what you need to remember. Now, hypoxic ischemic encephalopathy is one of the favorite topics of the examiner. Typically, to treat the hypoxic ischemic encephalopathy, we give neuroprotective mechanism as a mechanism. We give therapeutic hypothermia. Hypothermia is bad, but at the same time, hypothermia is also therapeutic. Especially, you want to avoid hypoxic ischemic encephalopathy. One of the favorite MCQs of the examiner is, what are the inclusion criteria for you to consider the therapeutic hypothermia? The gestational age 36 weeks and birth weight more than 2 kgs. Any evidence of fetal distress, history of acute perinatal event, biophysical profile less than 6 out of 10, cord blood pH less than 7 or base deficit more than 16, and abnormal neurological examination, abnormal EEG, they're all considered to be the important criteria in a case of preterm baby to avoid hypoxic ischemic encephalopathy. To give a therapeutic hypothermia is what you should remember. So when you give therapeutic hypothermia, where should the cooling of the body or head? It should start in the first 6 hours of life. And what is the target temperature during cooling? 33 to 34 degrees. And rewarming. Whenever rewarming after hypothermic treatment is done, what is the most common side effect? There can be coagulation abnormalities which can develop at the time of rewarming. So, what is this, doctor? This is, yeah, it comes next. CMV, let us talk about CMV. So torch group of infections, one MCQ जरूर आएगा कल के नीट पीजी एग्जाम में, torch group of infections. So there will be chorioretinitis in fundus, microcephaly. CMV में क्या क्या होता है? Cottage cheese or ketchup sauce type of CNS calcification. Periventricular calcification is the hallmark of the CMV. Second, rubella में क्या होता है? Salt and pepper type of a fundus chorioretinitis. Then rubella can cause PDA, sensorineural hearing loss, and cataract. And deafness is the most common manifestation of rubella. Similarly, blueberry muffin rash, rubella. Then in toxoplasmosis, you get a CNS calcification, but it is very diffuse. It's called soap bubble appearance. Then in the syphilis, there is an interstitial keratitis, salt and pepper fundus. And one important thing you need to remember, which is favorite MCQ, is all the torch group of infections CNS calcification nahi karega. If you look at syphilis, there is no CNS calcification. So all the following lead to CNS calcification except among the torch group is a favorite question.
/R measles lo also,
Huh?
microcephaly.
M/R. Blueberry muffin rash. There are many other conditions where blueberry muffin rash.
M/R.
Huh?
M/R.
Ekkada?
Microcephaly pakkana M/R ఉంది.
Mental retardation. So this is periventricular calcification, which you see in. And this is the salt and pepper chorioretinitis. These are all image-based questions, doctor. Congenital toxoplasmosis may, this is called as the, this is called as congenital toxoplasmosis may, this is called as, this is also calcification pattern. Now comes, doctor, what are the criteria? A very common thing that we all do, the physical examination in the newborn, of the newborn is a part of pediatric posting, learning it. Preterm versus term. How do you differentiate? Preterm, sole creases are there, anterior 2/3 only. Breast nodule is less than 5 mm. Ear cartilage is thin. There is a poor recoil. Hair is fine, woolly, lanugo, abundant. Testes are commonly undescended. And there are hypopigmented rugae. Labia are separated. If you separate the labia in female, hypopigmented rugae. Then if you take the term, the sole creases are very extensive. 5 to 10 mm is the breast nodule, and the ear cartilage is thick, good recoil. That is what you need to remember. Testis is descended and pigmented rugae will be found. So what is this, doctor? The sole creases in preterm. Now comes kangaroo mother care, KMC, not Kasturba Medical College. So what is the method of care of preterm? I mean, where do you use kangaroo care? Preterm or LBW infants. The main idea of kangaroo क्या होता है? Skin to skin touch between the mother and the baby, skin to skin touch. And Kangaroo nutrition means exclusive breastfeeding. Kangaroo position means skin to skin contact. Kangaroo discharge and follow-up means early home discharge in kangaroo position. And mothers at home require adequate support and follow-up. And until when will you continue the KMC? Until the baby achieves a weight of 2,500 grams and a gestation of 37 weeks. So Murali Bharadwaj coaching program is Kangaroo NEETPG preparation. Until when we will give this? Until you cross 140 in our grand test, we will continue to poke behind you by saying, did you study? Are you coming to class or not? Etc. etc. Of course, you are also Kangaroo students who make me to come to class Kangaroo. Huh? So so दीक्षा आप कल से क्या रखोगे ना? My dear Kangaroo Bharadwaj, did you start in the home? We all Kangaroo preterm babies are waiting. So now comes indications for positive pressure ventilation. After 20th point, we take a break, right? 20 paragraphs, 40 paragraphs a day is our maximum tolerable limit.
So you don't have class with the nurses today?
No. So all nurses went for Sankranti holidays. మళ్ళీ ఇదే ఉంటుంది సుత్తి వాళ్ళకు కూడా. మళ్ళీ వాళ్ళకు కూడా కంగారు కేరు బ్రెస్ట్ ఫీడింగ్ వాళ్ళకి ఇంకా ఇంటెన్స్ ఉంటుంది మనకంటే. యాంబో బ్యాగ్ ఎట్లా పట్టుకుంటావు, ఇట్లా తిప్పాలనా, ఇట్లా ముక్కులో పెట్టాలనా, మెకోనియం ఆస్పిరేషన్ ఎట్లా చేస్తావు, సక్షన్. సో నౌ what are the indications of positive pressure ventilation? Any apnea, heart rate below 100, persistent central cyanosis, or a low oxygen saturation in spite of giving oxygen free flow. They are all the indications for PEEP. Now coming to umbilical cord. Usually when do you cut the umbilical cord? 2 minutes in normal baby. Where do you cut it? 2 to 3 centimeters from umbilical base. So what is the normal cord length? 55 centimeters. If it is less than 35 centimeters, it is considered to be short. More than 80 is considered to be long cord. ये पूरा टेलर का measurements तो याद रखना है, क्योंकि entrance is not about brilliance, intelligence, knowing these things at least once. Umbilical cord has one vein, 2 arteries. Left is left, right disappears. What do you remember? Veins में left is left, right disappears. There are 2 arteries and 1 vein. So this is how you are applying the PEEP to the baby. Now coming to single umbilical artery, one of the favorite questions. Single umbilical artery is associated with renal and genitourinary abnormalities. So this is what you see, polycystic kidney and single umbilical artery. Single umbilical artery and polycystic kidney are associated. So genitourinary abnormalities are associated with the single umbilical artery. Otherwise 2 umbilical arteries रहता है. So you should remember that. Then esophageal atresia, tracheoesophageal fistula, imperforate anus and single umbilical artery which syndrome में होता है? Aneuploidies में, Edwards syndrome में होता है. Even diabetes, prematurity, asphyxia can cause single umbilical artery. And typically the closure occurs on 7 to 10 days. I mean the cord is supposed to fall. Buddudu. So so when will umbilical cord will that stump will fall down? 7 to 10 days. If prematurely fallen, what does it mean? Lately fallen, what does it mean? So premature fall of the cord means infection and sepsis. Alrighty. So that is what you need to remember. Now coming back to the toxoplasmosis. In case of toxoplasmosis, whenever the infant is born to a mother who has toxoplasmosis, they don't have any overt signs at birth. So when you evaluate for Toch group of infections, you may discover that, oh, this baby has unlike others. So if if the baby is having IgG negative, IgM equivocal in the newborn baby, when the IgG to toxoplasmosis is negative and IgM is equivocal means goda meeda pilli, neither jumping that side or this side. So it is a possible early acute infection. IgG equivocal, IgM positive, possible acute infection. IgG positive, IgM negative, infected with the toxoplasma more than 12 months. IgG positive, IgM equivocal, possibly infected with toxoplasma. Same, no? IgM, even if it is equivocal or negative, it is more than 12 months. But if IgG is positive, IgM is also positive, it indicates recent infection with toxoplasma less than 12 months. Achha, toxoplasma may one very peculiar thing occur in the fundus. What is that fundus called? Headlight in fog appearance. You remember we were discussing in ophthalmology. I don't know whether you are born that time. Yeah. Okay. Retinitis and all. So fundus of an active toxoplasma chorioretinitis showing classical headlight. Old movies में पूरा बारिश गिरता है और गब्बर जीप में ड्राइविंग करते हुए आएगा ना, तो headlight in fog appearance. So when that scene is happening only, mom used to close the eyes because there is going to be a violent scene. Nowadays, all violence, all sleaze, babies know more than the dad. Earlier days, don't tell dad how to produce babies. Nowadays, don't tell babies how to produce dad. So, what will you remember, doctor? Headlight in fog appearance. Tomorrow's NEETPG, they will straight away give you a fundus picture and ask you to recognize that. Favorite MCQ, doctor. What is the drug of choice to prevent the maternal toxoplasma going to child? Spiramycin. You remember that? Then any toxoplasma in pregnancy with fourfold rise in IgG indicate recently acquired infections. Generally, IgM is an indicator of recent. IgG is old. But IgG 4 times rise should always be interpreted along with IgM. Right? So that is a point you need to remember. Now coming back to the principles of cord clamping. So good to see Rajesh Reddy and many more who are all online. Now the whole country got that fever of NEETPG. 50 days आ गया ना, notification के बाद LH rise के बाद corpus luteum निकलेगा. अभी everyone is producing the progesterone, right? देखना है who will retain the conception, right? So cord clamping, early cord clamping, delayed cord clamping. Early cord clamping, what are the indications? When you should not wait for the 2 minutes also to clamp it. Before only, you need to clamp it if there is a prematurity, RH incompatibility, birth asphyxia, IUGR, baby of a diabetic mother. They are all the indications for early cord clamping. Delayed cord clamping, that is delay of 30 seconds is advised as a routine nowadays in all the cases. Coming to cord cape. that stump को कैसे carefully रखना. Triple dye, brilliant green, proflavin, hemisulfate, and crystal violet is one of the most effective, but it is a gold standard agent. Proflavin, hemisulfate, crystal violet, and brilliant green because of its bactericidal property, especially against the staph aureus of the infection. But current recommendation is no local application is advised. गांव में गए तो गौशाला से लाके काउ डंग को भी लगाते हैं. That's one of the very common causes for the spread of sepsis. And what will you assess in the cord blood? TSH, T3, T4 to screen for congenital hypothyroidism. Screening of inborn errors of metabolism, methylmalonic acid, everything is checked. And sampling of infant born to Rh negative mother need to be checked. And nowadays, all preservation of fetal blood, stem cells, there is a different world. Then cord is useful for preservation of stem cells. So that is the whole story, questions that commonly come about the cord clamping. Now, if you look at the separation of the cord, it takes 10 to 14 days on average, and delayed separation is, where do you see delayed separation? Early separation in sepsis and infection. Delayed separation whenever there is LAM. Favorite question. LAM का मतलब leukocyte adhesion molecule deficiency can lead to delayed separation. Factor 13 deficiency. What is factor 13 called? Clot stabilization factor. Then combined immunodeficiency, severe combined immunodeficiency. Antiseptics अगर apply करें तो sepsis early fall means antiseptics delayed fall. And infection can cause both early and also delayed, of course. Then cesarean section. So in all these things. And early separation can occur because the trauma, and even you do Brandt-Andrews maneuver to remove the placenta, no? So because of that excessive pull also. So this is all the story about the umbilical cord. We'll take a 2-minute break and restart. Please stay online. So, welcome back to the session, Doctor. Ballard scoring. What is the meaning of Ballard scoring? It is an objective method to assess the gestational age when a newborn is born. Subjective is looking at the creases, lanugo hair, and all that. Objective is Ballard. You look at the neuromuscular maturity, physical maturity, and between 20 to 44th week, you will use to uh, assess the gestational age after birth. So minimum score is 10, corresponds to 20 weeks. Maximum score is 50, corresponding to 44 weeks. Now, what are the criteria used in Ballard scoring to judge the gestational age of a newborn? Skin, ear and eye, lanugo hair, plantar surface, breastbud, genitals. And there is a new modified Ballard score, which uses the neuromuscular maturity additionally. So, favorite MCQ. What is that additional criteria in the new Ballard score? First of all, what is Ballard score? पहली बार सुन रहे हैं हम. So, उसमें क्या क्या क्राइटेरिया है आप ध्यान से याद रखना. So, typically the new Ballard score is an extension. Earlier, regular Ballard score 20 to 44 weeks. Na? So, extremely preterm babies who are closer to the 20th week, this integrity, neuromuscular maturity also is used as a criteria. Then EEG is used under the new Ballard score for gestational age assessment, and that will give you how is the EEG background. Typically, when the baby is more mature in the gestational age, there is a maturational progression of the EEG background is what you need to remember. So this is all the signs of the physical maturity: skin, lanugo, plantar surface, breast, eye, ear, genitals. They are the ones which are being assessed. Now, what is meant by fetal medicine? Assessment of how the fetus develops. So how many places do we read fetus? Embryology, pediatrics, cardiology, and also OBG. So finally, since it comes in multiple places, Jarur Puchega, how will heart develop? When will the neuroectoderm develop? All these stupid questions. So, doctor, chambered heart is formed by 6 weeks, nails and neck by 3rd month, and most sensitive period for teratogenic effect is 3 to 8 weeks. Radiation effect is between 8 to 15 weeks. Purely batti marne wala item hai, फिर भी. So this is how left, right atrium, left atrium, interventricular septum, and foramen ovale. So a 4-chambered heart typically forms by 6 weeks, okay, of intrauterine life. Now, advanced age of the mother, advanced age of father also. Buddhi ma, Buddha father. Both of them are dangerous, right? So what are the chances? More than 35 years. Mental subnormality. That's the reason if you take 30, 32 years to get a MD seat and you become pregnant and deliver, you become a risky mother. Be very sure. That's the reason better produce a baby while you are preparing only. Preferably. So Down syndrome is more common beyond 35 because mother's eggs are as old as her. So non-disjunction of the chromosomes is responsible for aneuploidies. At the time of meiosis, they are expected to separate. If they don't separate, then you get all these trisomies like Downs. So Down syndrome is more common. Then premature labor, Edwards syndrome, dizygotic twins, CNS defects, they're all common with the advancing age. Then how about daddy? more than 50 years. If daddy is old, that is also problematic. Marfan syndrome is born to a old daddy. Achondroplasia, craniostenosis. Then Down syndrome because the fusion of 21 and 22 occur because of the prolonged paternal age, not maternal age. Osteogenesis imperfecta, congenital deafness. Mostly skeletal system abnormalities occur if the daddy married mummy at his 40th age and still not sure to produce the kiddo. If the kiddo is born by the time daddy is about 50, then yeah, it is difficult. Now comes rubella. Rubella is the most common congenital infection leading to fetopathy. Favorite question of the examiner. Among the TORCH group, fetal congenital malformation most common with rubella. Rubella lead to miscarriage, abortion, embryopathies, fetopathies. Fetopathies means after third month. Embryopathies means up to third month. Then this is how typically cataract, congenital cataract, etc. That is what you see with rubella. Now, what are the antenatal predictors of a chromosomal disorder? This is one sure short MCQ in the tomorrow's NEETPG, doctor. Down syndrome, high nuchal fold thickness, reduced femur length, increased maternal serum HCG, inhibin, low PAPA, low AFP, low estriol. They're all the indicators of Down syndrome. So mainly two serum markers, PAPA, free beta HCG. Decreased levels of PAPA before 14th week of gestation means increased risk of Down syndrome trisomy 18. Increased level of HCG means increased risk of Down syndrome. So these are the two. Every NEETPG you go, a question milega. Now what are the Hall's criteria to make a diagnosis? So using all these markers, so everything are down in Down syndrome except HCG. Then coming to Patau, trisomy 13. Holoprosencephaly, cleft lip and palate, echogenic kidney, polydactyly, rocker bottom feet and microcephaly. Edward, trisomy 18. Spina bifida, cerebellar agenesis, radial aplasia, single umbilical artery and clubfoot. And there is a condition called congenital dyserythropoietic anemia type 2, type 3. In type 3, gigantoblasts are a classical feature. Type 2 may Hemp's test. What is Hemp's test? Hereditary erythroblasts, multinuclearity with positive as acidified serum lysis is called Hemp's. Hemp's is positive in dyserythropoietic anemia type 2, Greek and Latin. Right? But single liners in the tomorrow's NEETPG. So मेरे प्यारे भारतवासियों, इस टेबल को आपके दिल को अंदर रख के जाना. शूर पूछेगा डाउन्स में AFP लो, estriol लो, inhibin is high, HCG is high डाउन्स में. So Turner में AFP decrease, estriol decrease, HCG very high, inhibin A very, very high. So please remember this. And tomorrow NEETPG में one question आए तो give me a missed call. Right? Because you will forget now, I'll tell the answer from outside. ఎట్లైనా 50 కొట్టాలప్ప బిఫోర్ వి లీవ్ హోమ్. డీల్ ఉన్నదా ఎనర్జీ? 40 వరకు ఉన్నదా? ఓకే, డోంట్ వరీ. Totally there are 300, how many pages notes is given? 13. Totally, there is 35 pages notes, doctor. ఇప్పుడు ఏ పేజ్కి వచ్చినాం? ఫిఫ్త్ పేజ్. నాట్ బ్యాడ్. ఈ స్పీడ్లో కొడితే 4 days is enough to finish. Anyway, most of these things you can also read, but my job is some points to emphasize. So teratogenic drugs may phenytoin, carbamazepine, phenobarbital, valproate, progestins. Progestins, if you give masculinization of female fetus hypospadias. Valproate say coactation of aorta, neural tube defects. Phenobarbital is relatively safe in pregnancy, relatively safe in newborn also. Right? Then phenytoin can lead to bleeding because of vitamin K deficiency. Then diethylstilbestrol, once upon a time they used to give, nowadays not giving, but that lead to clear cell vaginal adenocarcinoma in the girls born to the mothers who took DES 15 to 20 years later. Similarly, if a boy is born to the mother who took DES, they develop testicular cancer. If OCPs are used and withdrawn during pregnancy, vacral abnormalities are common. Clomiphene citrate can lead to ovarian hyperstimulation syndrome and multiple births. And clomiphene is also known to lead to Down syndrome and NTD. So a woman on PCOD on clomiphene became pregnant and you did not discover that and continued on clomiphene, little risk is definitely there. Prednisolone can cause oral clefts, benzodiazepine can cause cleft palate and lip. Now coming to the torch group of infections. 6 to 8 weeks of pregnancy is the most difficult time where the risk of fetal transmission is maximum. Rubella complications most likely in the first trimester of pregnancy. And what are the serious defects in rubella? PDA more than PS, more than VSD, more than ASD. It does not lead to any conduction abnormalities. Now, CMV. CMV means not that CMV, another CMV. Continued mechanical ventilation. Right? Yeah, mechanical ventilation के लिए diaphragmatic hernia, meconium aspiration. These two are the important contraindications to be remembered. So when do you want to do chest compressions? Once more, I'm bringing back to you to the neonatal resuscitation. What are the indications for chest compression during the neonatal resuscitation? If the heart rate is less than 60, 60 is the benchmark. And when do you need to give the drugs in neonatal resuscitation? If the heart rate remains less than 60, even after 30 seconds of assisted ventilation with 100% oxygen, and additional 30 seconds of ventilation accompanied by chest compression. 30 ke baad, you need to push epinephrine, blah, 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 everything. And any delay in your reflexes to resuscitate the newborn, no? Lifelong, they need to live with cerebral palsy and all these birth asphyxia issues. That's the reason obstetricians, anesthetists, neonatologists, they are like a football team. Tak goal milte hi, pakadna, newborn baby, tak, you took it out. It should cry. If it doesn't cry, you have to cry. Right? So, coming to syphilis. Usually, in the first trimester, treponema does not attack the fetus. Why? What is the protective factor? It is the Langerhans cell layer. Langerhans cell layer. Spirochetes can cross the placenta, infect the fetus, but from 14th week of gestation. And in the syphilis also, if the mother is there is a primary, secondary, tertiary syphilis, no. If the mother is in a very early stage of untreated maternal syphilis, like primary, secondary, there is a greater risk. And the rate of transmission is 50% if the mother is suffering from secondary. Now, doctor, tell me and remember 4 drugs that can be given intratracheally at the time of CPR. Adrenaline, naloxone, lignocaine, atropine. Right? So, Lana, lignocaine, adrenaline, atropine, naloxone. They can be given tracheally. Then, is there any role for atropine and aminophylline and sodium bicarbonate in neonatal resuscitation? Atropine can be given tracheally, intratracheally, that's different. But you don't give it, there's no role for, because acidosis is there. Don't jump and give soda bicarb, because all that acidosis is respiratory acidosis due to respiratory distress or hypoxia. So that is the reason no role for soda bicarb, atropine and aminophylline in neonatal resuscitation. Tomorrow examiner will ask, which of the drugs have no role in neonatal resuscitation? If you happen to use soda bicarb to treat the acidosis in a newborn at the time of neonatal resuscitation, there is a greater risk of intraventricular hemorrhage, hypernatremia, pulmonary hemorrhage, especially in preterms. Then, for eclampsia, you give max sulfate, but that max sulfate, does it have any effect on the newborn? Yes, sir. Neonatal hypotonia can occur. So if the neonatal hypotonia is because of lot of max sulfate you push to the new mother, then how will you reverse it? Give calcium gluconate to the neonate to reverse it. Earlier days, they used to do suction of meconium with the delivery of the head of the baby if there is any meconium strained amniotic fluid. Do we do that? No, no more recommended. So what is the only situation where naloxone is given? Whenever there is any opioid-induced depression in the baby, then only naloxone is used, otherwise not much of role in the neonatal resuscitation. So how do you monitor the fetus? Fetal scalp pH. Fetal scalp, you pass a electrode to check the pH. Less than 7.15 means there is asphyxia. Earlier days they used to do oxytocin challenge test, but it is no more recommended to know the fetal well-being. Only NST, non-stress test is used. If non-stress test is non-reassuring, then you need to deliver the baby. Give the parachute and he will jump. Now comes perinatal HIV, one of the major topics in the NEETPG exam, doctor. What is the most common mode of transmission of perinatal HIV? It is intrapartum transmission at the time of delivery. Antenatal, interpartum, postpartum. Then it occurs due to direct contact of the maternal blood and genital secretions which are containing HIV. If you give transfusion, more than 90% chance of HIV transmission in pregnant mother. Generally, transfusion is not an easy decision. You need to be doubly careful because it's a very good source for HCV, HIV, in spite of using so many lab parameters. Then, what is the estimated risk of the mother to child HIV transmission, doctor? If you don't do any intervention, like giving antiretroviral therapy to the mother, etc., etc. During pregnancy, risk is 5 to 10%. During labor and delivery, risk is 10 to 15. During breastfeeding, 5 to 20%. Overall, without breastfeeding, it is 15 to 25. And with breastfeeding up to 6 months, 20 to 35. With breastfeeding for 18 to 24 months, 30 to 45%. So India, like impoverished countries, what is our country? I don't know. India is shining, right? So India, like country, even if mother has HIV, it is advised that she takes adequate antiretroviral therapy and continue the breastfeeding. So important is the importance of breast milk. Without treatment, the likelihood of HIV passing from mother to child is 15 to 45%. Whereas with ART and intervention, it can be reduced to less than 5%. ये percentages की बात है ना डॉक्टर, गर्मा गर्म क्वेश्चंस पूछते हैं एग्जामिनर. You have to remember precisely these percentages, right? So next, after going home, जरा bookmark करो आपके notes में, app में, ठीक है? Another 6 questions. Bharat Bhushan will wake up from REM sleep. Tough time, no, Bharat. You have to do jogging. We'll arrange a table tennis board. Truly, it is very boring, but more boring subjects we survive now. What is all that stupid anesthesia? Huh? Jaiswal got absent teachers during revision of anesthesia. हो गया सर, हो गया, क्या हो गया? Oh my God. So, see, every subject is like a newly discovered boyfriend. कुछ दिनों के बाद बोर हो जाता है, right? Only excited is the first 20-30 slides. जरा deltoid दिखाओ, जरा gluteal दिखाओ, okay, enough. Everyone has the same. So otherwise you are the control freak. I don't want to get along with you. So this also is becoming control freak. So many numericals to remember. So perinatal HIV. So recommendation for mother is what? Lifelong ART in the form of single pill. What single pill? It has triple drug. Tenofovir, lamivudine, efavirenz. Favorite question of the examiner: what is the drug you prescribe to the mother? Tenofovir, lamivudine, efavirenz is the best option. HIV positive pregnant, breastfeeding women, whatever be their CD4 count or whatever be the duration of pregnancy, they may be in 3rd month, 2nd month, 1st month, doesn't matter. Tenofovir, lamivudine, efavirenz. Will you remember this for me? Yeah. Then ART regime for the pregnant women who earlier had exposure to NNRTI, non-nucleoside reverse transcriptase inhibitor, if you want to prevent parent-to-child transmission. Suppose if she is taking earlier NNRTI, there is a chance of risk of resistance in this population. So, efavirenz in this is an NNRTI. So, in this combination, efavirenz is not effective. Thus, these women require a protease inhibitor. So, tenofovir, lamivudine, lopinovir is the one which is being suggested. Mali ivanni okkati sharp questions. इदी दिल में लगा के रिवीजन करना है डॉक्टर. श्योर शॉट आने वाला क्वेश्चंस है. Thank you for the 20 audience who came back after the break. That shows that class is interesting, is it not? Or FOMO, fear of missing out. Huh? FOMO. చివరికి మా గిరిజా మేడం అన్నారు, ఆ నోట్ చదివి మా ముఖాన్ని కొట్టండి సార్, మేము చదువుకుంటాం, మాకు చదువుకోవడం రాదా అయింది. Initially you hold our hand and make us walk for a while. After that, once we got into that first 100 paragraphs are over now. Actually, remaining things you can read if I give you the notes and maybe PowerPoint, right? But still, you come. Otherwise, I don't. I will forget pediatrics, right? So, what is the ARB prophylaxis that you give to infant? Short-term use of nevirapine syrup up to age of 6 weeks, and this can be increased up to 12 weeks. Even though he does not have HIV, you give nevirapine syrup up to age of 6 weeks. It can be increased up to 12 weeks if the ART to mother was started in late pregnancy, or during or after delivery if it is started. If the mother started late, baby also should continue longer. And if the woman already, if the infant of a woman who previously had exposure to nevirapine, then instead of syrup nevirapine, you give syrup zidovudine. You'll remember, right? Now, perinatal HIV. How do you want to prophylaxis? If the CD4 count is less than 250, cotrimoxazole need to be given. Similarly to the mother. And to all the HIV exposed infants under the age of 18 months, cotrimoxazole prophylaxis is recommended and started at 4 to 6 months of age. Suppose if there is a HIV TB co-infection who are not able to tolerate efavirenz, then you give a boosted protease inhibitor based regime need to be given. And whenever you are using a boosted protease inhibitor regime, rifampicin in ATT should be substituted by rifabutin. And whenever you have TB and HIV together, otherwise, not talking about pregnant, first treatment will be TB, then will be HIV. Then doctor, HIV is transmitted through breast milk. Maximum in the first 5 months of lactation. In developed countries, top feeding is advocated, and developing countries, breastfeed for 6 months followed by rapid weaning is recommended. So we are still developing country, doctor. Until one more attack of COVID is required for America to fall down, right? Until then, we are developing only. They are already developed. I watched these 1960 movies now. I enjoyed 1950s. Do you watch?
Yeah.
What a kind of buildings and this thing, man. Today, Gachibowli, Madhapur में जो होता ना, वो सब 1940, 1950 movies में है. Cha! Ridiculous, no? Those guys who went to America in 1950, 1960s, they already have enjoyed what after 70, 80 years later we are seeing. All right. So, what is the method of prevention of vertical transmission? At the time of the labor and delivery, if the mother is pregnant with HIV, minimize the vaginal examination. Avoid prolonged labor. Consider oxytocin to shorten labor. Use the partogram to measure the duration of labor. Avoid artificial rupture of membranes. These are all affirmative statements. They will ask A, B, C, 1, 2, 3 correct, 1, 2 correct, 2, 3 correct, all that crap. Don't use suction unless absolutely necessary. Avoid trauma episiotomy. Early cord clamping. You need to do early cord clamping. And delivery is, if the mother has HIV, NVD is better than cesarean. This is favorite question. You will be tempted to answer cesarean is better. No, 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 no. Understand? Normal vaginal delivery. What did you think NVD bole to Diksha? Non-vegetarian delivery. non-vaginal delivery bit. Then use of half the time I am taking to understand these shortcuts, acronyms of this thing. What is that? PP? PPTCT means prevention of parent to child transmission. Okay? Uh, uh, do you know what is that? NP? What was that?
NV.
Yeah. Do you know what is my NPWRBL? NEET PG preparation by not reading but listening. If you are already exposed to Murli Bharadwaj, then you need to change it. If you're already exposed to long-term coaching somewhere else, you need to change the drug because you already developed resistance. So, avoid artificial rupture. That's very important. Now, what are the teratogenic drugs? Alcoholism, fetal alcohol syndrome, all the fetal alcohol syndrome features you need to know. LSD leads to a very peculiar thing called fractured chromosomal anomalies in fetus. It leads to chromosomal breakage syndromes, LSD, if the mother happened to take. So, small eye openings, smooth philtrum, thin upper lip. Lot of our classmates used to have, right? Those days we didn't know about this. Otherwise, we would have evaluated them, right? So this is what fetal alcohol syndrome, right? So I think our what's her name? Your classmate?
Anam. Anam, sir.
Arn?
Anam. ANAM.
Anam. Anam is so happy to see Kaushik. Oh my God. So what is her happiness, This fellow is also not settled. And why Kaushik is happy? Such a brilliant girl ko seat nahi aaya. So I'm also happy. You don't get, I don't get. We both are happy. We're on same bench. All unhappiness, doctor, let me tell you, during preparation, frustration atana. Frustration is when you see other fellow. चल ओ फालतू फेलो एमडी डर्मेटोलॉजी में आ गया मैं what is this man, what is this crap man, all because of this girlfriend whom I dumped. So if she dumped, that's a different story. अभी तो आजकल नया गर्लफ्रेंड भी नहीं मिल रहे. So forget about comparisons, doctor. Your life is your life, their life is their life. Enjoy the way it is, and always tell your partner that देखो, today I am a beggar, but tomorrow मैं एक दिन अमीर बन के दिखाऊंगा, right? So, and the one who trusts you will remain with you, right? So when you are nothing, when somebody supports, there is a true partner of life. Otherwise, what is the fun? When you all accomplished, and tomorrow if Bharat became MS orthopedician, some girl came and said, I love to marry you, means what's the big deal? Today, Bharat, when nothing is there, only Usmania 95th rank in MSET is there. If any girl says, tell me, I'll arrange the marriage. Huh? So, yeah. Then cocaine can lead to abruptio placenta because cocaine is a vasoconstrictor. It can lead to preterm labor. Mobius syndrome can occur because of the cocaine. Heroin can lead to irritability, hyperactivity, tremors, and poor concentration in infancy. Then smoking lead to LBW. This is a very big problem. Those who regularly smoke became pregnant. To control smoking is very difficult. So I leave the literature for you to quickly review. Tomorrow, examiner will ask each of them. Then continuing the exodus, dicomerol lead to Kaumarin syndrome, severe bleeding in neonate, and IUD. Fetal warfarin syndrome, otherwise called as. So they will have abortion, hypoplasia of nasal bones, extremity, very important. Stippled epiphysis is a classical feature of fetal warfarin syndrome. And they will have calcification of the cartilage, which looks like chondrodysplasia punctata, is most characteristic of fetal warfarin syndrome. The problem is warfarin को और cartilage में calcification को कुछ संबंध है क्या? फिर भी याद रखना पड़ता है. Then ACE inhibitors always absolutely contraindicated. Renal tubular dysgenesis, lung hypoplasia, oligohydramnios, anything can happen due to ACE inhibitors. Lithium can lead to which anomaly? Epstein's anomaly. Mithuna Bede, what is Epstein anomaly?
Large atrium, smaller ventricle on the right.
Or large atrialization of ventricle.
Yeah.
So abnormally placed.
Valve.
Right. So ventricle becomes small, atrium is too big, and it is completely atretic. And this is one of the cyanotic condition. Cyanotic condition. क्यों? The blood need to pass from right to left and then get rerouted. So that is the reason right जब left से मिलता है, अच्छे लोग बुरे लोग से, बुरे लोग अच्छे लोग से मिलता है, सब कुछ बुरे हो जाते हैं. तो misoprostol can lead to Mobius syndrome. This also. Mercury exposure, Minamata disease can lead to cerebral palsy and microcephaly. Thalidomide can lead to phocomelia. Then vitamin K can lead to hemolysis and severe neonatal jaundice. Vitamin K. Vitamin D can lead to vitamin D hypersensitivity. And if vitamin D excessively exposed to the mother, the baby can develop Williams syndrome. What is meant by Williams syndrome? There is a triad of clinical features. Infantile hypercalcemia, Elfin phases, and supravalvular aortic stenosis. Kaushik, check William मारे तो कितने MCQs आ रहे? Then that is good. Search में in the score app. William. It also comes under left bundle branch block is remembered as lead V1 is W pattern, lead V6 is M pattern, is left bundle branch block is William.
36 questions and 4 notes.
4 notes ना? वो 4 notes में क्या क्या notes हैं देखो. William क्यों आ गया?
One is chromosome abnormality. Chromosome 7. One is congenital cardiac defect associations.
That is
Supravalvular aortic.
supravalvular aortic stenosis. Then రెండేనా?
Another William is father of orthopedic oncologist.
Oh, that
William Penikin.
And here this is Williams syndrome. Congenital microdeletion of lava chromosome.
Elfin phases and all that, right? So very simple है. Buffet system of आपका Android है iOS? Android no? iOS? Oh, आप तो मेरे टॉप रखता. So okay, mostly by tomorrow, day after tomorrow, we'll get it in iOS also. So chloramphenicol lead to gray baby syndrome. Quinine lead to thrombocytopenia, immune mediated. Fluoroquinolone, always be careful. Fluoroquinolones are contraindicated even in less than 12 years of age group because they can lead to cartilaginous defects. Very peculiar thing, favorite MCQ of examiner, erythromycin lead to pyloric stenosis. A pyloric stenosis का है वहाँ erythromycin. Of course, erythromycin what it does is it will affect the motilin in the gut. So fundamentally, pyloric stenosis and all associated with motility and all that, right? So streptomycin lead to deafness. Anyway, you know that. Now, what are the various categories of drugs, doctor? Category A, no fetal risk. Penicillin, cephalosporin, erythromycin, clindamycin, rifampicin, ethambutol, nitrofurantoin, ritonavir. They're all category B. No fetal risk is demonstrated. Category C is not adequate human data. Category D is danger, like tetracycline, streptomycin, tobramycin, metronidazole, etc. So please do review this list, doctor. I mean, important highlighted points. Over 42. Chapter Bharat. So, very good. And thank you very much to 21 online classmates who came to the class. एवरी डे मिलेंगे पढ़ेंगे और एक दिन कामयाब होके दिखाएंगे एंड नो रिग्रेट्स एंजॉय एवरी मोमेंट ऑफ योर प्रिपरेशन इफ यू फील लाइक क्राइंग टेल मी आई विल आल्सो क्राई विथ यू राइट मेरे पास कर्चीफ अवेलेबल है एंड टेल योर फ्रेंड्स वॉट एवर प्राइस दे वांट they will get the subscription activated. Right now.